This is really a milestone, and we've had too many milestones in this pandemic, but this is certainly an important one where there's now the go-ahead. Pfizer was not prepared, as far as I understand it, to supply vaccine to Australia until it had approval. Otherwise, they would have been giving valuable doses here in the hope of approval, but now they've got it and they can go ahead and supply vaccine. And then there's important batch testing to be done to make sure that the vaccine is as delivered in terms of the batches. Because it's one thing to say the vaccine's safe, you've got to make sure that the vaccine that's going to go into your arm has been safely made and not hasn't got infection in it or anything like that, which is a fairly routine process.
So 10 million doses, which will help 5 million people. Clearly we need more, and we're turning to AstraZeneca to fill that hole, aren't we? But that is yet to be approved. When's that going to happen?
Well, it's not entirely clear, but it'll be over the next 2 or 3 weeks, I imagine, because now they've got clear air, now they've got Pfizer out of the way. The Astra approval, I mean, I've got no insight or knowledge of what they're doing, but from the data, it's a much more complicated vaccine to approve because the trials were not, I'm going to use the word clean, but clean in only the sense of data. What happened with the trials with Astra was they changed as they went along. And that's always a problem with trials, and it's a problem for regulators because you're getting these things. It's not the trial as originally designed is not the trial they delivered. And just very briefly, so for example, people now will know, well, many people know of the problem. No, it wasn't a problem they had, but they ended up giving half a dose to a group of people in Britain who were aged between 18 and 55 instead of the full dose. They thought they were giving the full dose, but the supplies that they'd got from another manufacturer were not as concentrated as they thought. So it ended up being half a dose. And then when they gave half a dose followed by the full dose, they got 90% efficacy in terms of preventing disease. Whereas from the other trials where they gave 2 full doses, they got 62% efficacy. But it wasn't designed to give the half dose. So regulators get very uncomfortable with that. If it wasn't designed to find that out, yet they found it, how reliant can they be? And then the other thing that happened was they were testing a 1-dose, 2-dose regime, and some people who got 1 dose, they discovered the antibody level wasn't high enough, so they called them back later for a 2nd dose. Now, some of those got that 2nd dose quite late. And again, what they found was that if you got it 3 months later, it was a 90% efficacy. It's a complicated reason why, but it's because the body generates antibodies to the vaccine because the vaccine is a virus in its own right. Again, I suspect the regulator is going to find that uncomfortable because it wasn't part of the original trial. But it is open to the regulator to say half dose, full dose for under 55s or doses a month, 3 months apart. But that's not what the trials were designed. So they've got to work that through because if they approve the standard dose regime, then it's 62% efficacy. But it could have a higher performance than that.
As you mentioned, Norman, it has been 1 year since the first diagnosed case in Australia of COVID-19. It's hard to believe it's a year, isn't it? What lessons have we learned over those 12 months that we can take into the future?
Well, it'll take you about a year to tell you that, Ros, but essentially when that arrived, we didn't really understand asymptomatic spread. In other words, and that's what's made this a pandemic. This is a virus that spreads when you don't have symptoms or you're pre-symptomatic. So that was a big one. We now know about the immunology of the spike and how that produces antibodies. We now know that there's long COVID, where people get this long tail of disease, of illness. Recently, we now know that probably this disease produces autoantibodies against our own body and the immune system. So what we've learned is that this is a profound disease that affects all sorts of different parts of the body, very different from influenza, with a higher mortality rate. We found out all that. And yet in this year, we've, even before this anniversary, they had already published the genetic sequence. By around this time, the group at Oxford University had already pretty much designed their first vaccine. And the others had 2, so we had vaccines within 3 or 4 weeks designed.
Yeah.
Extraordinary.
But it is changing all the time, isn't it? We have these new variants, the UK, South Africa, there's one in Brazil as well, I believe. Are we constantly going to be playing catch up?
Either yes. Yes is the most likely answer to that. So the South African one, Brazil's less well known, but they're likely to be more. So the British one's certainly more contagious. South African likely to be, and the disturbing research that's coming through about the South African vaccine, small studies, is that there may be a bit of escape from the vaccine, so that we may have to work around the vaccine, which might mean new vaccines every year or even sooner than that. So don't book up your foreign holiday just yet.